Good evening, everyone. So I finally will be able to try and put across a few points before I start. It's good to have only people who are interested in listening here. That's where the actual messages really go out. So my talk today is in complete accordance with the NMC guidelines. Don't have a reimbursement for this talk, and I have no pharma interest in any of these. So it's a very easy job for me now. Since yesterday you've been seeing a lot of this barbed pharygoplasty, you've seen how it is done, you've had so many discussions on all around it. My 15 minutes I'm going to utilize to tell you how all roads lead to Rome now. That's the difference. So we know this is the classical modified UP3, and over the years when you start developing a niche practice, when you're known for something, then you will get a lot of patients which have been operated before, and you see results later on. And I don't call these as failures, I call these as unimproved patients post-op, because probably the proper counseling, pre-op counseling was not done, and the proper decision making of how to go about it was probably not done. I see plenty like this, I've seen them, and we all have seen these, and we now know why UP3 has failed. It's no brainer now that UP3 standalone is a big failure in the long run. So what exactly happened? We started thinking, and then what happened was we got into relocation pharyngoplasty, where you picked up the palatopharynges from here and you brought it onto the soft palate. So there's a lag between the cursor and this, so don't mind that. Then we realized, okay, this is also not helping very much. So then there was something called as the expansion pharyngoplasty. So you picked up the palatopharynges, took it a little bit more laterally onto the pterygoid hammerus. Again, probably this was not giving very good results. Like I said, you have to keep your mind open, keep doing new things. This didn't help. So we went and found a structure at the lateral most part of the oral cavity, which was the most rigid structure there. You can't go any lateral to that. And we decided to hook on the palatopharynges onto the pterygomandibular raphe. So this was like the complete evolution that kind of happened onto palatal surgery. And where we had a problem was the selection of palatal procedure. And now I'm using the word, it was $1 million question. It's no longer $1 million question. It's a very clear-cut answer when you see what you have in front of you. These are the number of surgeries that everybody has been discussing over innumerable workshops. And this is what we have, this is what we have. And everybody talks and says each surgery has got its own indication, which is perfect. They have their own indications, they had their own indications, out of which we already know that this is out. So the UP3 and its Hazar modifications are totally out now. We know zeta palatoplasty has got very clear-cut indications. Whenever you have a very thick palate which is actually falling back onto your posterior pharyngeal wall, and the thickness of the palate is so huge that anything to do that with the palatopharynges is not really going to help. So that's where you go in the center and you're cutting off the entire palate and opening it up like a book. So that's a clear-cut indication for zeta palatoplasty. So we have zeta palatoplasty also, which is now out of this picture. What are you left with? Decision makings. You're left with relocation, expansion, barbed, and anterior palatoplasty. Now I just showed you in the evaluation that with the relocation and the expansion, you were not getting that much of exposure. I mean, you're not getting that much of lateralization and opening up of the entire airway. So where are you left with now? So when you know that a particular procedure, and I will now go ahead and show you how that particular procedure not only addresses the vertical or the horizontal segment at the palate level, but also extends down onto the pharyngeal tube. So the pharynx is a tube with lateral pharyngeal walls and a roof at the palate. So when you have a procedure like this, which is very clear cut, you do a barbed pharyngoplasty and you do an anterior palatoplasty with that same patient, and straight away you have addressed the anterior, posterior and the lateral. And this is what my argument was in the earlier debate when I did it, and I told you that if you have a procedure which is already giving you that particular expansion, why are you even contemplating on the expansion and the relocation? They are no longer required when you have something in your armamentarium. So I don't need to really show you all of this, since yesterday you all have been seeing how the whole thing has to be done. You do the marking of the lateral pterygomandibular raphe at the lateral most part. You do that at the both sides, and then you have the markings in the center. as has been shown to you by the people who were operating. There's a midline, hard palate, soft palate marking, and in the midline of the anterior pillar and the base of the uvula, you have that. So basically you start from here. These are very diagrammatic representations. You start from there, you're going to that midpoint that you've created, and then from there you're going and picking up the palatopharyngeus muscle from there, your pterygomandibular raphe from there, coming back from there and picking up your palatopharyngeus here, again going back and hooking that onto the pterygomandibular raphe, again coming back and picking up your palatopharyngeus muscle from here. So what I need you to understand here is the entire length of the palatopharyngeus here is being taken care of. And then you're going back there and you're coming back to the center over here. Now when this happens on both sides, and when you're actually pulling up the sutures on both sides, then that makes life so much easier. Imagine the kind of expansion that you will have at the antero-posterior level here, laterally also, and in the entire vertical segment of the lateral pharyngeal wall. Now this is what was demonstrated to you yesterday also. I'll just take you quickly through. These are the sutures. You start from one place, come out onto the pterygomandibular raphe, then from there, from the midline you've gone onto the pterygomandibular raphe. From there you're coming and again coming into and picking up the palatopharyngeus muscle. This is a video which is into 4. It's not that my hands or the camera is shaking that much. It's in the speed of into 4. And then you're coming back again, picking up that palatopharyngeus muscle and bringing it back onto the pterygomandibular raphe. It's a very, very simple process. Not too much of cutting, bleeding, whatever. Of course, needless to say, tonsillectomy is a prerequisite in all this. So see here how much of a pull you get when that barb gets pulled up. See that lateral wall. You've seen that enough in the surgery, so I won't get into all of that right now. I need to go forward. You can have an oral view while you're doing it. You can have an endoscopic view of the same thing. You'll see the amount of pull that you get as you're making the sutures. You can actually see the lateral pull there at the same time. They're not playing in tandem, but that's the idea that I'm trying to give you. And then of course you have what is called as the anteropalatoplasty. Now it's such a simple procedure, I'm not even going to play the video. A simple rectangle there, mucosa removed, submucosa removed, and 3 or 4 sutures in 2 layers where the muscle to muscle and the mucosa to mucosa. So this brings up the anterior palate, and the pharynx has gone taken up entirely by the lateral palate. So what this is doing is it's just remodeling the entire narrow pharynx. It advances the soft palate also, and it's splinting the entire lateral pharyngeal wall, right? And I'll play you that same video which I played earlier at a slower speed today, now, for you to understand how the entire length goes. Selection is very standard selection that we discussed about, but the important thing to understand is your posterior pillars should be pliable and webbed and thin. If you have very thick pillars which are not going to come anterolaterally, then you're not really going to get anything. And of course you have to do a simple scopy with that to decide and see at to what level you're actually getting the. So if you see that as we go, you will see the narrowing of the lateral pharyngeal wall, and whether it's a concentric or not. So this is absolutely otherwise okay, but then gets concentric. Whether it's concentric or not, the decision making becomes so simple. There is nothing that we have to bother about. The only times when I don't do this surgery is if it's under 8 years of age. Obviously BMI here I put as 32. This is an older presentation of mine. It's now coming down to 30, and sometimes even lesser than 28 is when I do it, and not before. And definitely not with the skeletal abnormalities, if at all. Post-op remains the same. It's a very uvula sparing procedure. It preserves your entire palatal muscle, so you have no issues with pharyngeal function. There's no change of voice, and most importantly, post-tonsillar bleeding is also not there because your entire fossa is now closed. Now what you have to understand is this is how mindsets change. I've taken this with permission from my very dear friend Professor Vicini. And if you see over the years what they have done, they also did a lot of UP3s, palatal flaps, expansion sphincters. But way back in 2019 itself, they started moving to Barbed. And of course COVID hit in between, but when I just last spoke to him last week before this event, his count was almost 1070 plus. So they have started moving and shifting because it's a clear-cut physiological, anatomical, sensible procedure to do for the palate. There is nothing else which requires you to rack your brain so much and figure out what you want to do. This is one procedure which is addressing the anteroposterior as well as the lateral wall. So why are you breaking your heads over anything else? And this is where I told
show you about the palato-pharyngeus muscle and how we do the barbed. So this is the posterior.
The entire length of this muscle gets
going here, and you see where the palato-pharyngeus is. It is where the pterygomandibular raphe starts from and goes all the way here. And when we are doing the barbed pharyngoplasty, the idea is to get this palatopharyngeus entirely on the lateral wall.
The entire length goes lateral.
There is this much shift of the lateral wall on both sides, and that's how the expansion of the pharynx, the lateral pharyngeal walls, happen.
So on both sides you can see vertically you have the entire length, and laterally you have so much expansion to the lateral side. Thank you, Suhas. If you're there in the audience, Dr. Suhas Desai was with me for a CTP fellowship. Good to see him, I got this up. So anyway, we had a lot of discussions with Vichini on this, that over a period of time we keep brainstorming about this, that is this really enough? But that's what happens. You don't start jumping the gun. Although this is one procedure which is there now and all others can be put aside, you still have a lot of questions that are unanswered which you need to put your brain to. You have to document the airway size pre and post, and you also need to know how long that fibrosis really holds. Sample sizes of 1070 across the world are probably sometimes not good enough. The Indian subcontinent also has it, but the problem is this is happening sporadically. I will do 100, somebody else will do 100, somebody else will do 300. Unless that data is collected together to get the huge numbers, we cannot come forward. But rationally and scientifically speaking, it is the most simplest and logical thing to do in the palate, which does not require you to do a DICE. My take-home message is very strong over here, that for a palate surgery, the decision making, for a palate surgery underlined in inverted commas, for a palate surgery decision making, a DICE is not important. It doesn't change your decision making at that. And if you need to change your decisions with regard to base tongue and the epiglottis, you can always do it in the next stage procedure before that. So don't waste your invasive investigations. And the same thing applies to dynamic MRI. You do not need to do it before the nose and the throat is tackled. You save these investigations for when they actually make a difference to your decision making. What I have not really discussed I still have enough time, so I'll keep that open for question answers. What has not been discussed is it's all been termed as barbed, but there's no longer a barbed suture that is required. So it's now coming down to even using simple vicryl or PDS sutures, where you can take these sutures and have intermittent sutures also. It doesn't really have to come up there and pull up the entire palate if you're doing the anterior palatoplasty with that. Now these are slight modifications which will take some time. Yes, there are complications which are not too bad. There's only extrusion that happens. You have to recut, re-remove. It's redoable. There's absolutely no problem with that. So all in all, a very simple, safe, physiologically and anatomically sensible, logical procedure which does not require too many investigations prior. Of course, sleep study most important, awake flexible scopy most important. So use your mind to think rather than just learn the techniques. You will learn, the procedures are very simple. Everybody will say, okay, this one has indication, that one has indication, this works better in my hand, that works. An open mind person has to keep in mind that, okay, this works better in my hand. I may be doing a post-oral. I learned post-oral tympanoplasty when I graduated. Today I don't do anything post-orally at all except huge mastoids. But everything is end-oral, mini-end-oral and endomeatric. Why? Because this makes sense. It makes sense for your patient. It is better for your patient to do that. I didn't say don't do an audiometry before a tympanoplasty. I'm saying change your mindset and move to something which is very logical. Thank you very much, ma'am. Sir, I'm within my time. I'm open to questions and I hope I have been able to change that mindset.